Hi, everybody. Welcome back to Coding with Christine Hall. 2023 ended with an absolute bang. We've got so much new information, new guidance that was brought to us at the end of 2023. And I thought it would be kind of interesting if we took a time to discuss how some of those changes really affect us. And I was talking to some friends of mine, and what was really interesting is that a lot of people don't understand the anatomy of the CPT code. We all know what CPT codes are, right? They help us get paid from those payers. But what exactly are we communicating to a payer, or what exactly is already built into that CPT code when we submit it? What do we all know about that CPT code? Let's get a little bit intimate with that CPT code. Now, the rest of this season, we're going to be chatting with our subject matter experts across the country about CPT and sections of the CPT coding book and different sections, the surgery section, anesthesia section, evaluation and management, my personal favorite. We'll also be chatting with experts in radiology, path and lab. We'll be talking to experts in the medicine section. We also have a few experts that are going to join us this season on modifier usage. So I wanted to kind of dig into what is a CPT code, right? So for more than 5 decades, physicians, healthcare providers, they've been using the current procedural terminology, or CPT. We use this to communicate to other colleagues, other healthcare professionals, patients, hospitals, payers, your insurers, right? We communicate the procedures that have been performed. Now, the AMA, the American Medical Association, they first developed and they published CPT in 1966. A little bit before me, not too much, but a little bit before me. And the very first edition that came out, it was intended to help encourage the use of standardized terms and descriptions to document those different procedures in a medical record. It helped us communicate accurate information on procedures and services to payers on insurance claims. And it provided a base for a system to evaluate different operative procedures. And it also created a way to communicate or to report statistics like how many COVID infections did we have to the CDC or to our local health departments. Now, the fourth edition, which is the edition that we currently use today, it was published back in 1977. But trust me when I tell you that it has been periodically updated to include changes to procedures and to changes in medical technology that we see, right? Things are definitely not the same. You've heard me tell you dozens of times. The only thing we can really count on in the industry of healthcare is change, right? So the CPT book is no different. It is updated periodically, annually, with those new technologies, with that new approach there. Now, in 1983, I'm a historian, so I love the history of things. But in 1983, CMS, the Center for Medicare and Medicaid Services, which used to be the Healthcare Financing Administration, or HCFA, right? They adopted the Healthcare Common Procedural Coding System, or HCPCS. And HCPCS was divided into 2 separate publications. The first publication is CPT. That's the level 1. That's what we use to submit medical claims to payers for procedures, for services that are performed by our physicians, our nurse practitioners, physician assistants, and any other qualified healthcare professional, PT, OT, speech language pathology, audiologists, licensed clinical social workers, psychologists, and the list is very long of those providers, those qualified healthcare providers, right? The second level is the HCPCS level 2. And those codes, we use those primarily for medical devices, supplies, medications, and some other types of items and services that are not included in the CPT code set. There might be similarities in CPT and HCPCS codes, but trust me when I tell you they're different. They're not word for word there. So with this adoption, CMS actually mandated that we needed to use HCPCS, level 1 CPT and level 2 HCPCS codes to report all services to the Medicare program. Now, as time went on, we also saw that CPT was designated by the Department of Health and Human Services as the national coding standard for all healthcare providers to report services and procedures to insurance payers or to patients or to other entities, statistical entities, right? And that was actually part of the HIPAA Act, the Health Information Portability and Accountability Act of 1996, made official in 2000. It takes us some time to get things in legislation. Anyway, I wanted to take a look at a specific code. I wanted to see specifically how that code is designated. Now, I do a lot of work on reimbursement, and one of the denial codes that absolutely drives me crazy is CO50, denied for medical necessity. Wait a minute, what are you talking about? Or sometimes payers will revalue a payment, or a payer will deny it for an improper modifier. And I think to myself, how do they know this? Where does this come from? Well, we need to take a look at the specific anatomy. So the first code I want to talk about is 13132. Now that's the repair, complex repair of the forehead, the cheek, the mouth, the neck, the genitalia, the hands and the feet. It's a pretty good code there. It's 2.6 to 7.5 centimeters. And it's a closure of more than one layer. It is of the superficial and the fascia. It goes into the dermis, the epidermis to the dermis. It includes extensive undermining, maybe even exposure to the bone or cartilage or tendon. Maybe there's some debridement of the wound edges, or maybe they place retention sutures. So this is a pretty deep repair. Again, it's a layered repair, and it is for a pretty complex wound that we're reporting. However, when we look at that code, 13132, there's actually some indicators that have been assigned to that code for payment purposes. So let's take a look at that. Bring that up. Let's look at that specific code and its indicators there. Wow, take a look at this. So you have a status A. Well, we're going to talk about what does that mean for this code. Global surgery. Now, a lot of us know what global surgery is. This global surgery package is 10 days. Facility pricing, professional components or technical components. Does this procedure include a professional and a technical component? Well, all of that's built into the CPT code. What is the payment? What part of that is for preoperative work? What part of that is for postoperative work? What part of that is for the actual repair? We're also going to look to see, can we do multiple surgeries on one day when we're performing the 13132, this complex repair? Can it be done as a bilateral procedure? Can we have an assistant come in and assist us with this procedure? How about two surgeons? How about a team of surgeons? How about endoscopy? All of that is actually already built into each one of these codes. So I wanted to kind of run through, what does each one of these indicators to this code mean? So let's take a look at the global surgery indicator. Now, remember, our code had a global surgery indicator of A as an apple. It means that this is an active code. However, if this had been a global surgery code of B, right? If this had been a surgery code B indicator, the B indicates that the professional fee schedule or the payment is always bundled into anything else that happens in that day. So if you have a code with an active status of B, you're never going to receive any payment for that specific code beyond what you were paid for any other service on that day. So, for example, last year, or not last year, actually, I remember COVID makes me feel like we had this really long year that went from 2020 to 2023. But in 2020, 2021, we had a new code that was released, 99072. And I remember that a lot of providers, because of the description, it was a description that stated that that code represents that this encounter required additional supplies and services based on a respiratory condition that the patient presented. So going along with COVID, that code 99072 was meant to report that that particular visit required additional services. So maybe we had to have the medical assistant come in and clean the room with a higher disinfectant than what we had normally, the normal standards were, because it was COVID, or we used an extra pair of gloves, or we used extra masks or extra materials for that particular encounter. What providers didn't understand at that time is that that particular code had a status indicator of B. So it was just for reporting purposes. It was simply to let CMS know that that visit did indeed include higher materials that were used, higher resources that were used, but it didn't actually give us any more money. It was a communication code. Your status indicators of C state that these are excluded from the physician's fee schedule by regulation. So there's no payment, like our 99499. There's no payment assigned to it. It's an unlisted code. We need to submit information to show, to prove what we did during that specific visit there in order to have that calculated by the payer there. But there is no payment that has been automatically assigned on any codes that have a status indicator of C. Not valid for Medicare purposes, status indicator of I, status indicator of M. This is a measurement code only. It's for reporting MIPS, for reporting HEDIS. So there's no payment on a status indicator of M. Status indicator of N, like Nancy. It's a non-covered service. Again, it's that 99072, non-covered service. Or X, statutorily excluded. And that stands for services that isn't in the legal definition of physician services. We see a lot of the equipment, the supplies may have a status indicator of X, right? So that explains to us sometimes why there is no additional payment. The one that we see a lot in denials is the status indicator of B, right? And that tells us that it's not going to be covered. Now, remember, if we go back to our code description, the next area that we see is the global surgery. And let's click over to global surgery and see what that means to us. So each CPT code is assigned a global surgery. 000 just means that this is maybe an endoscopic procedure or a minor procedure. It is a surgical procedure, but the global period only extends to today. So whatever happened today is all included in that global surgery component. So we're talking about all the preoperative work, all the postoperative work, all of that is included in the payment. And I'm going to show you that breakdown in just a minute. Now, the next one is our 10-day global period. And remember that 10-day global period means that it's today plus the next 10 days. And they said that those are usually those minor procedures where if something were to go wrong or to validate that everything went right, we would need to see that patient within those 10 days to be able to make that determination. And that is included in the payment and in the reimbursement. It's calculated. So it's not that you're not getting paid for it. It's already calculated in the reimbursement. So when you see that global surgery, know that any additional visits during that 10-day period has been allocated in the overall payment. The next one is the 90 days. 90 days, if you read it, it says it's the day before the surgery, it's the day of the surgery, and it's 90 days after the surgery. So it's really like 92 days, right? And it's important to know that that also includes all the preoperative and all the postoperative and any other postoperative services that might be in that 90-day period, the evaluation and management visits during that 90-day period there. Very important to understand that it's built into that. One of the things that I want you to remember is that CMS is always revaluing our CPT codes. And if you notice, last year when they changed our hernia codes, they removed that major surgery, global surgery time period from the hernias. So you could report any postoperative hernia visits. If you notice the reimbursement for the hernia services also went down because they had to remove that global period that was accounted for in the payment. So M is for maternity, X is for the global concept does not apply. Evaluation and management has a global surgery of X, doesn't apply to evaluation and management. These are surgeries. Y is that the global concept applies and it's established a post-operative period for that particular procedure. So it's not a 10-day, a 90-day, or a 0-day. It's a specific day from the payer that they're saying is the post-operative period. And then the Z is the global concept applies, again, for that post-operative period pricing there. So a Y or a Z is a surgical procedure, but the payer decides, or the MAC decides, what that global period will be. They might determine that that procedure has a 10-day global period, or they might determine that that procedure has a 90-day global period. It's not automatically assigned. It's assigned when it gets to the payer. Now, let's look at the next box. So if we go back to our original code, the next box is, I'm going to skip facility pricing because we're looking at it from a pro fee perspective. We're going to go right into that professional component, technical component. Now, there's a lot of indicators to tell us whether it's a professional component or a technical component. So when you see that 0, we see that on evaluation and management. There's no professional component or technical component. It doesn't apply. It's a physician service. It's evaluation and management, right? 1 would be diagnostic tests and radiological services. These usually include both a professional and a technical component. When you see this indicator, we're really talking about Modifier 26 and Modifier TC could be used on this particular code when it has a PCTC indicator of 1. 2 means it's a professional component only code. So, for example, our EKGs, we have a global EKG code, we have a technical EKG code, and we have a professional EKG code. Now, the professional EKG code only has a PCTC indicator of 2. Means it's only covering that professional service. It's not intended to cover the technical part of it, and vice versa. So that 93005, the technical component only, it's going to have a PCTC indicator of 3, just that technical component to it. Again, they're telling us what kind of CPT code is this, right? It's a technical component only code. 4, it's a global code. It means that you can't use modifier TC or 26 because it's a global code only. Can't break that up. So again, your 93000, that's a global code. Can't break that up. The 5 is an incident to code, means it is a service that is usually performed by an ancillary staff service. We normally don't see the physicians doing that. Most of the time, you'll see that indicator on there. 6 is a laboratory physician interpretation code only. 7 is a private practice therapist service code. Now, we don't assign these indicators. Remember, these indicators are already assigned to the CPT codes. 8 is a physician's interpretation code. It describes the professional components of clinical laboratory. So there's an example there, 85060. And 9, it means that the concept of professional or technical doesn't apply to this at all. So it is not, it's more of a medicine section where in that particular instance, we don't have a professional or a technical component to it. All right, let's go back to the original code. I wanted to show you for a second, I wanted to talk about the post-operative, intraoperative, and preoperative payment percentages. Each code, surgical code, will automatically have those percentages allocated to the code. So for example, this complex repair that we're looking at, 13132, 10% of the payment is to cover that preoperative, evaluating the wound, making the decision that a complex repair is needed versus an intermediate repair. That's included in that postoperative. Cleaning the wound, preparing to repair the wound, that's all included in that preoperative percentage. So 10% of the payment is going to go for those particular types of activities for that complex wound repair. 80% of the payment is for the actual repair, and 10% of the payment is for postoperative care. So this is a 10-day global period. 10% of the payment covers that additional day or covers instructions, the bandages that we might need to secure that wound. All of that's included in that 10% there. Now, let's move on to the multiple surgery. Multiple surgery modifier is usually when we would refer to a modifier 51. When would we use that modifier 51? Or sometimes you might use a modifier 59. And the 0 means that there's no payment adjustment rules for multiple procedures. So you can report multiple procedures and there's no differential in the payment, right? 1 means that the first procedure will be paid at 100%. The second of multiple procedures on that day are going to get paid at 50%. And the third or more procedures that are performed on that day are going to get paid at 25%. It doesn't matter what modifier you add. It doesn't matter how you arrange these. That particular code already has this multiple procedure payment indicator built into it, right? An indicator of 2 means that they're going to pay the first procedure at 100% and every procedure after that at 50%. 3 is there are special rules there for endoscopic procedures. Think about an endoscopic procedure. Listen, if I had an endoscope and my provider noticed that in my esophagus there are polyps and he removes a polyp, well, I darn sure don't want him taking the scope out, waking me up, asking me, hey, Christine, I noticed that there was another polyp and I wanted to remove it, but it was going to be a different type of procedure and it might have an additional. I don't want that. I want that when my doctor has me anesthetized and the scope is in me, that he takes care of everything he needs to take care of in that one instance. So when it comes to those scopes there, we have some specific billing procedures that's already built into the CPT code. 4 means that there is a technical component with a diagnostic service reduction. So we're using maybe an intraoperative ultrasound or fluoroscopy, and that particular code, when we use fluoroscopy will be paid at 50%. It's already part of the code. And then 9 means that there is no multiple procedure concept that would apply. Again, if we look at our evaluation and managements, they're all going to have a multiple procedure concept of either 0 or 9. It's an evaluation and management. Let's go back to our original code. Now, bilateral procedures. You see that bilateral procedures, you're either allowed to do it bilaterally or you're not allowed to do it bilaterally. How about our assistant surgery? Assistant at surgery. So these are your modifiers 80, 81, and 82. Can you use them? That's a great question. Well, it comes down to the indicator that's attached to that CPT code. An indicator of 0 means that there's a payment restriction for assistance at surgery that is applied to that procedure, unless you send in supporting documentation. So if it has an assistant at surgery indicator of 0, you got to send records. If it has an assistant at surgery indicator of 1, it's a statutory payment restriction for assistance at surgery for this particular procedure. So Medicare may not pay for an assistant at this particular type of surgery. And think about this one. We're talking about a complex repair. Maybe they don't allow an assistant for a complex repair and they feel that the surgeon can handle that by themselves. Or 9, it doesn't apply whatsoever, right? Oh, did I talk about 2? 2 is a payment restriction for assistant surgeries. They don't apply to this procedure, and Medicare may not pay for the assistant. And then 9, the concept doesn't apply. All right, let's bounce back. We're getting close to two surgeons, co-surgeons, two surgeons, modifier 62. And there was a lot of guidance this year on modifier 62, especially when it came to the vertebral tethering. We've got some new codes for vertebral tethering for scoliosis, and there was some specific guidance in CPT regarding the use of modifier 62. So this is where you have two primary surgeons that are each doing a portion of the same procedure there. They are both primary surgeons. The indication on the CPT code 0 says, we don't pay for two surgeons to do this. We feel like one surgeon can handle that, right? When it has a modifier indicator of 1, it means that, yeah, two surgeons probably should be doing this transplant, right? Or something major like that. 2 is that co-surgeons are allowed and it doesn't require documentation if you meet the 2 specialty requirements. So we have that, meaning that we have 2 different specialists that are performing parts of that surgery. So again, maybe you have someone who's having a cancer resection. You might have the surgeon coming in to remove the cancerous tissue, and maybe a plastic surgeon, general surgeon removing tissue, and plastic surgeon going in to do the repair. Both different specialties, both of them providing significant components of one procedure there. And 9 means that the concept doesn't apply. All right. Team surgeons, let's take a look at that real quick. Team surgeons, your modifier 66. When the CPT code has an indicator of 0, the team surgeon is not allowed for that procedure. When it has an indicator of 1, team surgeons could be paid, right? But you're going to make sure that you submit documentation to indicate why we needed a team of surgeons. Maybe that was, you remember years and years ago, it was probably like 20 years ago, there was a lady who had 8 babies, and they needed a team of surgeons in there to help with that delivery, but also to make sure that they were there to help with any of the babies as they came out. Number 2, team surgery is allowed. We pay it by the report. And then 9 is a concept doesn't apply to it. A lot of our procedures have that concept of 9. Now, we talked a little bit about our endoscopic based already. So I don't need to really dive into that. We talked about when, we have an endoscopic procedure, colonoscopy and endoscopy, we really don't want that provider waking us up. So sometimes we will have that indicator there depending upon that particular procedure. This is a complex repair. It's not appropriate. There's no reason to report that. Now, all of that into consideration, all of those indicators go into the RVU process, the relative value units. Let's take a look at those. Now let's take a look. So let's take a look at those. We know that each one of our CPT codes, it incorporates payment for a work RVU. Work is the time, the skill, the training, the intensity to provide the service. So when we look here, the work RVU 4.78 for that complex repair reflects that our providers needed to have that skill, that training. It accounts for the amount of time that it takes to do that repair. All of that is included in that work RVU. The PE, or the practice expense RVU. Well, these are the costs of doing business, right? You need to have your office, your utilities in your office, your equipment in your office, the exam tables, the otoscopes, the surgical supplies, the sutures for this particular procedure, and any staff members that might be there assisting, the medical assistant. How about you, the coder biller, who is assigning the codes, and you are also billing out the claims? All of that is accounted for in that practice expense RVU. And then malpractice. Malpractice is usually a very small percentage of the payment, and it's just there to make sure that we've accounted for any professional liabilities for that specific type of procedure. What's the liability of a complex repair? And all of those RVUs are calculated and multiplied by the annual conversion factor. And that's how we get the reimbursement for each one of the procedures, each one of our CPT codes. So when we think about how a CPT code is reported, think that in that code, we are telling a payer that we already know that that specific code has a designation of whether or not it has a global period. It has a designation of whether or not that code is a payable code, those indicators, right? The payer already knows whether that procedure has a professional component or a technical component to it. The payer knows whether we can, well, how do they pay when there's multiple procedures? All of that is already built into the anatomy of the CPT code. And so a lot of times when I'm working denials, I will really have to go in and see what those status indicators are that are for that particular procedure. And did we meet all of those status indicators? Did the modifiers support those status indicators, right? Am I communicating like information with what's already associated with that CPT code? So I know that's a lot of information, but I thought it was important that we kind of hash out the CPT code before we move into each section of CPT and talk about those codes, so that when we say that there is a specific code that maybe has a co-surgeon component to it, that you know that that's already built into the CPT code itself. You know that that's already been accounted for. It's important for us to remember that all of our CPT codes, their surgical codes, they include the professional component and they include the technical components to those as well. So please make sure that you have liked and subscribed our YouTube channel, that you've signed up for our newsletter on our website. We've got a lot of exciting things planned for the year 2024, and we want to make sure that you are involved on top of everything. If you have any questions about today, make sure that you reach out to me. I'd love to get to meet you. So until we meet again in 2 weeks with our very special guest, and I'll keep you on the edge of your seat until next 2 weeks from now to find out who that is, as we dive into the world of CPT. Thanks so much for joining me, and have a wonderful day, everybody. Thanks for watching.